Good day everyone, we are Group 1 and our topic is Microbiology of Dental Caries. In this presentation, we'll explore how bacteria contribute to the development of caries and its relevance in dental practice. Here is an overview of the key points we'll cover, from the basic background and microbial causes to plaque behavior and caries management. To begin, I am CLARINE SANTOS and I'll be discussing the epidemiology of dental caries. First, dental caries is a multifactorial microbial disease. It happens when bacteria in the mouth ferment dietary sugars, producing acids that lead to progressive demineralization of the tooth surface. It's considered one of the most common chronic diseases worldwide, affecting people across all age groups. Children and adolescents are highly vulnerable due to high sugar intake and still developing oral hygiene habits. The elderly are also at risk, especially due to factors like root exposure, gum recession, and dry mouth from medications. Lastly, people from low-income communities tend to have higher caries prevalence due to limited access to preventive care and dental services. On this slide, we focus on the major risk factors for developing dental caries. One of the most critical factors is frequent sugar consumption. When we consume sugary foods and drinks often, bacteria produce acid more frequently, which weakens tooth enamel. Poor oral hygiene allows plaque to build up, giving bacteria more time to damage the teeth. Low fluoride exposure, whether through toothpaste or drinking water, reduces the enamel's resistance to acid. Irregular dental visits means problems like plaque, tartar, or early caries may go unnoticed and untreated. And lastly, xerostomia or dry mouth reduces the natural cleansing effect of saliva, allowing bacteria to thrive. These factors create an oral environment that supports acid-producing bacteria, which damage the enamel. Dental caries is more than just an individual problem, it's a public health concern. It's influenced not only by personal behavior, but also by environmental and socioeconomic factors, such as access to fluoridated water, dental education, and healthcare services. That's why effective preventive strategies are essential. For example, community water fluoridation helps strengthen enamel and is cost-effective on a large scale. Oral health education programs, especially those targeting schools and underserved communities, teach proper brushing, dietary habits, and why regular dental visits are important. Dental sealants can also protect the most cavity-prone surfaces of teeth, especially molars, by sealing out plaque and food particles. Understanding these factors is essential in preventing disease and promoting oral health across communities.
Good day, everybody. I am MARGARETH, and for my part of the presentation, I'll be discussing the classification of dental caries by where the lesion starts. So, dental caries is a localized breakdown of tooth tissue driven by acids that bacteria release when they ferment the sugars we eat. The spot where that process begins shapes how the disease develops and how we detect it. First is the pit and fissure caries. It takes hold in the deep grooves of molars and premolars and in the lingual pit of the upper incisors. So why is it susceptible? This narrow crevices drop plaque and freshly erupted enamel here is still slightly softer. So acids from the microbiology dominated by Streptococcus mutans and later lactobacilli quickly create white or brown stains that can progress to a small surface, opening over a larger hidden cavity. Second is the smooth surface caries. It attack the broad, flight slides of teeth, most often just below the contact point between neighboring teeth, because plaque tends to stagnate where brushes can reach. Early on, you'll spot a white patch that left unchecked turns brown or cavitates. So for its microbiology, primarily involves S mutants due to its ability to adhere to smooth surfaces and produce acid. Third is a root surface caries. It develop on exposed cementum or dentine once gums recede, a situation common in older adults or anyone with dry mouth. So why is it susceptible? Gum recession exposes root and cementum dissolves more easily than enamel. So for the microbiology, Actinomyces species, alongside S mutants and lactobacilli, produce clinical appearance yellow to black soft lesions that spread sideways near the gum line. And finally, recurrent or secondary caries appear around the margins of existing fillings or crowns when tiny gaps, overhangs, or an aging seal let plaque accumulate. The same acid producing bacteria invade, creating a dark line or softened gap at the restoration edge. For its microbiology, similar to primary caries, which is the S mutans, lactobacilli, and other acidogenic bacteria colonize the restoration margins. To conclude the classification of dental caries, Pit and Fisher caries hide in the grooves of back teeth. Smooth surface caries form on the sides, especially between teeth. Root surface caries attack exposed roots after gum recession, and recurrent or secondary caries sneak in around old restoration. That would be all for the classification. Sumi Senese will now walk you through the clinical presentation.
Let's now break down how we can observe and identify the progression of caries based on what we see clinically in the mouth. These visible signs are important because they help us determine what stage the disease is in and whether or not it can still be reversed. The earliest visible sign of dental caries is what we call a white spot lesion. As you can see in this image, it looks like a chalky white area on the enamel, usually near the gum line or between the teeth. At this point, the enamel surface is still smooth and intact, and it hasn't broken down yet, which means the damage is still reversible. With proper brushing, fluoride use, and dietary changes, this part of the enamel can actually remineralize and heal over time. That's why early detection is key because it gives us a chance to stop the decay before it becomes permanent. Now, if the white spot lesion isn't treated, the surface of the enamel begins to break down and becomes rough to the touch. This leads to the formation of a small cavity or hole, which we call cavitation. At this stage, the damage becomes irreversible, meaning the enamel has been lost permanently and the tooth will now require restoration, usually through a filling. Interestingly, the patient might still not feel any pain at this stage, especially if the lesion hasn't reached the dentine yet. As the caries progress further, they reach the dentine, which lies just beneath the enamel. Unlike enamel, dentine is softer and more porous, containing tiny tubules that lead directly to the pulp chamber. Because of this, decay can spread faster once it reaches the dentine. Clinically, we might observe that the lesion now appears darker, even yellowish or brown in color. At this point, the patient may begin to feel sensitivity, especially when eating or drinking something cold or sweet. This sensitivity happens because the bacteria and their acids can now stimulate the nerve endings through those open tubules. Without proper treatment, the infection continues its path inwards and reaches the pulp, which is the soft tissue at the center of the tooth containing nerves and blood vessels. When this happens, the pulp becomes inflamed, and the patient may experience sharp, spontaneous, or lingering pain. This pain may even occur at night or without eating. At this point, the tooth is considered severely infected. The usual treatment is a root canal, which removes the infected pulp to save the tooth. If left untreated, the pulp can become necrotic, meaning the tissue dies and the infection can spread beyond the tooth itself. In the worst case scenario, if the infection continues beyond the pulp, it can spread to the apex or tip of the tooth root, forming a periapical abscess. This is a localized collection of pus caused by the body's immune response to the spreading bacteria. Clinically, this may present as swelling near the affected tooth, a visible gum boil or pus discharge, facial swelling, fever, or general discomfort. At this point, the tooth is at serious risk. If the infection isn't controlled, it can lead to more dangerous systemic issues, such as cellulitis or bone infection. Treatment options might include root canal treatment, surgical drainage, or even tooth extraction.
Good day, everyone. Today I'll be presenting on the microbiology of dental caries with a focus on how caries are diagnosed in clinical settings. The accurate detection of dental caries is such crucial for early intervention and effective treatment. So let's explore the main diagnostic methods used by dental professionals. First, Let's discuss visual and tactile examination. This is the most basic yet essential method for detecting dental caries. This technique involves both inspecting and feeling the teeth. During a visual exam, the dentist looks for discolorations, surface breakdown, swelling, or inflammation. Tools like dental mirrors and overhead lights help enhance visibility. In the tactile portion, an instrument called an explorer is gently used to probe the tooth surface. This helps the dentist to detect changes in texture such as softness or roughness, which may indicate decay or demineralization. Although simple, this method is often the first step in identifying caries, especially on easily visible surfaces. Next is radiographic imaging, which is a crucial diagnostic tool, especially for detecting caries that are not visible to the naked eye. First, we have the posterior bite-wing radiographs, which focuses on the back of the teeth and the areas where adjacent teeth touch, called interproximal areas. These are common sites for hidden caries. Bite-wings help detect cavities between teeth and can also show early signs of bone loss, which is important in periodontal assessment. Periapical radiograph is another important type of X-ray. It captures the entire tooth from the visible crown to the root tip. This allows for a detailed view of the surrounding bone and tissues. Dentists use periapical films to detect issues like deep caries, root infections, bone loss, and even abnormalities in tooth development. Then we have the panoramic radiograph, also known as the orthopantomogram or OPG, that provides a broad view of the entire mouth in a single image. This imaging technique is especially useful for identifying large-scale issues such as impacted teeth, jaw abnormalities, or widespread caries. It's commonly used in routine dental exams and treatment planning. Lastly, we have an advanced diagnostic tool, which is the laser-induced fluorescence, and this is a non-invasive technique used to detect caries, plaque, and even bacterial biofilms. How this works? First is a laser illuminates the tooth, exiting its molecules. Then healthy and carious tissues emit different types of fluorescence. Third, a sensor captures these fluorescence signals. Finally, the fluorescence patterns are then analyzed to determine the presence and severity of dental caries. This method is highly sensitive and can detect early caries changes that traditional X-rays might miss. So in summary, diagnosing dental caries involves a combination of techniques: visual and tactile examination for surface changes, radiographs for hidden or deep lesions, and laser fluorescence for early detection and precision. Understanding these tools helps us appreciate the complex process of maintaining oral health.
Next is the etiology of dental caries. So dental caries is a multifactorial disease, meaning that it results from the interaction of several factors over time. For a carious lesion to develop, 4 main factors must be present simultaneously. These are plaque microorganisms, substrate, host and teeth, and time. Now let's break down these 4 factors. So first is the plaque microorganisms. So these are the bacteria that form on the tooth surface, particularly the Streptococcus mutans. These bacteria metabolize sugars and produce acids. Number 2 is the substrate. So the substrate refers to the fermentable carbohydrates, mainly sucrose, which serve as food for the bacteria. Number 3 is the host and teeth. These refer to the tooth structure and the role of saliva, which I'll explain in more detail in the next slides. And lastly, time. The longer teeth are exposed to acid attacks, the greater the risk of demineralization. Now, let's focus on the host factors. First, we have tooth structure. Not all teeth or areas of a tooth are equally resistant to caries. For example, areas with less fluoride content or thinner enamel are more susceptible. Next is saliva, which plays a crucial role in protecting the teeth. The flow rate of saliva helps physically wash away food and bacteria. Its composition is also important because it contains calcium and phosphate ions that help remineralize early enamel lesions. Saliva also has a buffering capacity, meaning it can neutralize acids produced by bacteria. Plus, it delivers fluoride, which enhances tooth resistance to caries. Now, onto the diet, specifically sugar consumption. There is a direct relationship between dental caries and the intake of carbohydrates, especially sucrose, which is considered the most cariogenic. Sucrose not only provides fuel for bacterial acid production, but it also helps bacteria stick to the tooth surface and contributes to plaque formation. So research shows that populations consuming more sucrose have a higher caries rate, and both short-term human studies and animal experiments confirm sucrose's role in caries development. It's also important to highlight that the frequency of sugar intake matters more than the total amount. Constant snacking or sipping on sugar drinks increases the time teeth are exposed to acid. The stickiness and concentration of sugars also affect how long they stay in contact with teeth. Other sugars like glucose and fructose are cariogenic too, but less so than sucrose. Sugar substitutes like xylitol, which is a sugar alcohol, are much safer and are often used in chewing gum and baby foods. To conclude, the etiology of dental caries is based on a complex interaction between plaque bacteria, sugars, the condition of the teeth and saliva, and time. Understanding these factors is essential for both prevention and clinical management of dental caries.
For microbiology, this focus on several bacteria species involved and explain how they relate to different plaque hypotheses and tooth decay. So dental plaque is a sticky biofilm that builds up on our teeth. It contains many bacteria that interact with our diet, especially the sugars. When these bacteria break down sugars, they produce acids that can erode the enamel, leading to dental caries or tooth decay. And for specific and non-specific plaque hypotheses, there are different theories about how caries begin. The specific plaque hypothesis says that one or a few specific bacteria, like the Streptococcus mutans, are the main cause. The non-specific hypothesis says many bacteria are involved together. On a third view, the ecological plaque hypothesis combines both, saying that the sugar intakes change the environment, allowing acid-producing bacteria to dominate. And for role of mutant streptococci, the S mutans is one of the most important bacteria in caries. It can produce acid quickly, survive in acidic environments, and made a sticky substance to help plaque stick to the teeth. It's often found before cavities form, and higher level usually means the higher risk. For lactobacilli, the lactobacilli aren't usually found early in caries, but they are very common in different lesions, especially in dentine. They love low pH, produce lactic acids, and help the caries progress deeper once it's started. Now, for actinomyces role, like Actinomyces naislandi and Actinomyces viscosus, these are commonly associated with root surface caries, especially in older adults. They are filamentous, facultative anaerobes that colonize early in a plaque formation. While they do produce acids, they are less acidogenic compared to Streptococci mutans. They tend to prefer non-shedding surfaces like exposed dentine or a root surfaces. And for the role of Bilonella, this genus includes Bilonella farbula, which is interesting because it's not directly a cardiogenic one. Instead of producing acid, the Bilonella actually uses the lactic acid produced by the other bacteria like the Streptococci mutans and convert it into a weaker acids. This may help reduce the acidity of the plaque environment. So, Bilonella might actually play a protective role in a plaque ecology.
Good day everyone, I am BIANCA and I will be discussing plaque metabolism and dental caries. Dental caries starts with plaque metabolism. When we eat sugary foods, especially sucrose, oral bacteria feed on them and produce acids. These acids lower the mouth's pH. Once it drops below 5.5, enamel starts to break down in a process called demineralization. If this happens frequently, tooth decay sets in. It's a constant battle between damage and repair, and too much sugar tips the balance toward decay. Plaque metabolism basics. Here's how plaque bacteria work. After a meal, they absorb sugars and break down glucose through glycolysis, forming pyruvate. Under low sugar, pyruvate becomes harmless byproducts like ethanol. But with high sugar intake, it turns into lactic acid, the main driver of enamel demineralization. Bacteria also create glucans and fructans from sucrose, which help plaque stick to teeth and store energy. This boosts their ability to cause damage. Impact on dental caries. Mutants Streptococci and Lactobacilli are acid-producing and acid-tolerant. They drop the plaque pH and keep it low, damaging enamel. The stiffened curve shows this effect. A sharp pH drop after eating, followed by a slow rise. If sugar is eaten often, the mouth stays acidic, leading to lasting demineralization and decay. Frequent acid attacks, not just sugar amount, drive caries forward.
Good day, everyone! In this presentation, I'll be talking about the management of dental caries, or simply how we handle tooth decay in a step-by-step way. We don't jump straight to gels or extractions. Instead, we start with the least invasive option and only move forward when necessary. So let's go through the process from prevention to treatment and how we keep the tooth as healthy as possible. Now let's begin with our step 1, preventive management. This is the first and most important step where we focus on prevention even if there's no cavity yet. The goal is to stop the problem before it starts. So what do we do here? We brush with fluoride toothpaste, we floss daily, limit sugary foods and drinks, visit the dentist regularly, apply fluoride varnish, use sealants especially for kids, and do a caries risk assessment. This step is for patients who are still cavity-free or at early risk. It's all about protection. Step number 2, non-invasive treatment. Now let's say we see early signs of caries, maybe some white spots or shallow lesions. At this stage, we can still reverse the damage without drilling. What we do is we apply fluoride to help remineralize the tooth, reinforce proper brushing and diet, remove plaque or biofilm through good hygiene, and keep monitoring the lesion. If the cavity is still small and cleanable, we give it a chance to heal naturally through good hygiene and fluoride. Step number 3, minimally invasive treatment. If a small hole has formed and brushing can't clean it anymore, it's time to act. But we still want to keep things gentle, so options include fissure sealants, which refers to thin coatings for molars, atraumatic restorative treatment or ART, which refers to the involvement of no drills, just hand tools and filling, preventive resin restoration or PRR, where part is sealant and a part of small filling, and lastly, repairing old restorations instead of replacing the whole thing. Now we begin treating the tooth, but we're still trying to be conservative. These are small, tooth-saving steps. Step number 4, restorative treatment. When the decay goes deeper into the dentine or even the pulp, we need to fully treat the tooth. Treatments include fillings, composite, amalgam or glass ionomer, crowns for weak or broken teeth, root canal if the nerve is affected, and extraction but only if we have no other option. When the damage is severe, we restore or replace the tooth to prevent further problems. Lastly is our step 5, maintenance and follow-up. Even after the treatment, our work isn't over. We continue monitoring and helping the patient stay cavity-free. We do regular checkups, reapply fluoride if needed, reinforce brushing and diet habits, monitor old lesions and fillings. Management doesn't end after treatment. We keep checking to make sure the problem doesn't come back. We manage dental caries in a step-by-step and tooth-friendly way. From prevention to full restoration, the goal is always the same. Save the tooth and keep it healthy for as long as possible. That's all for my part on the management of dental caries. Thank you for listening, and now I'll turn it over to the next presenter.
Next is the ecological plaque hypothesis, a modern concept in dental microbiology that shifts the focus from a single pathogen to the overall balance of the oral microbiome. When environmental factors like frequent sugar intake disrupt this balance, the plaque environment becomes more favorable to disease, resulting in tooth decay. So, what is dental plaque? Dental plaque is a natural biofilm that forms on the teeth and gums. In health, it includes a wide range of microorganisms, some acid-producing bacteria in low numbers, and many beneficial ones that help neutralize acids or produce alkali. As long as pH, salivary flow, and diet are in balance, the plaque remains in a stable state. This allows the natural repair process of remineralization to balance out demineralization, keeping the teeth protected. Problems begin when the environment is disrupted, especially through frequent intake of sugary snacks and drinks. Plaque bacteria metabolize these sugars and release acids like lactic acid, lowering the pH. When the pH stays low, acid-tolerant or aciduric bacteria like Streptococcus mutans and Lactobacillus thrive. Meanwhile, beneficial acid-sensitive species die off. This imbalance leads to mineral loss from enamel and eventually tooth decay. This slide compares the two opposing processes on the tooth surface. On the left side is demineralization, which begins when plaque pH drops below 5.5 due to acid production. Acids dissolve calcium phosphate from enamel. On the right side is remineralization, which occurs when the pH returns to neutral, allowing minerals, mainly from saliva and aided by fluoride, to restore the enamel. Maintaining this balance is essential in preventing cavities, and this model shows it's the environmental shift, not just bacteria alone, that drives decay. In a healthy mouth, the plaque community is diverse and balanced, supported by stable pH levels and adequate salivary flow. Some species like Streptococcus salivarius and Streptococcus sanguinis help raise pH, while others like Veillonella consume lactate, offering protective effects. But frequent sugar intake disrupts this balance. Aciduric species like Streptococcus mutans and Lactobacillus dominate in low pH while protective species die. If the pH remains low over time, the result is demineralization that exceeds repair and eventually caries.
For my part, I'll discuss the microbiological tests used to assess dental caries. These tests are designed to evaluate the presence and activity of cariogenic microorganisms, particularly Streptococcus mutans and Lactobacilli, which play key roles in the developmental of caries. Microbiological testing helps us identify patients who are at high risk of developing dental caries. These tests can measure bacterial load and help guide preventive or restorative strategies. For example, high counts of Streptococcus mutans correlate with increased caries activity. Several tests are used in dental settings. The CRT test is popular. It assesses both Streptococcus mutans and Lactobacilli levels using a simple saliva sample. Dental kits are another option. They use deep slides incubated for a few days to show colony growth. These are semi-quantitative and easy to interpret. While helpful, microbiological tests are not perfect. They don't always predict who will get cavities, since many factors influence caries risk, like diet and saliva flow. That's why they should be interpreted along with a full clinical exam.